Hi everyone, my name's Julia Stowe and I work in the immunisation department in Colindale in Public Health England, and I'm an epidemiologist, which means I join up the dots. So I'm not a neurologist, I'm not a clinician, and I'm sure you guys all know much more about the condition than me, but I can show you some of the data from the cases that have been reported in the UK, so I think that'll give you a nice picture of what's been happening. So I'm talking on behalf of the AFP, we call it AFP, National Incident Task Force. So that brings together public health experts from England, Wales, Northern Ireland and Scotland together on regular meetings, and we form this task force. So, as Ben told you, the US first reported their unexpected cluster of cases in 2014. That's that published report he gave. And as he said, they were like polio-like symptoms affecting one or more limbs with no apparent sensory loss, and they had this characteristic MRI scans. And these cases were temporarily associated, so they were in close time with an increased circulation of this D68, the peaks that Ben showed you. So that was back in 2014, but it wasn't until 2018 that we really saw this increased reports of acute flaccid paralysis cases, and we did this through our enhanced surveillance of the polio virus. So Public Health England have to routinely monitor polio in the UK, and we report this to the World Health Organization because we need to monitor the polio vaccine, and that's I work in the immunisation department, and that's how I've kind of come into this. So these reports of acute flaccid paralysis that weren't polio, so we test these cases for polio first of all, they weren't polio, so we tested them for other enteroviruses, and this D68 did come up. So we had this spike of cases, and so we set up this task force that I just described in October 2018. So the purpose of our task force is really to, first of all, to investigate if these cases are polio. And so when we've done that, we also, and we've excluded that, we look for other viruses, including other enteroviruses, especially D68. There is other enteroviruses that have been seen in other countries. There's a 71 which has been seen in China, which sometimes give neurological problems as well. But so we do all the virology testing here in Colindale at PHE. And another purpose is we want to really characterise the illness, so we get the reports in, and we also want to look at the long-term follow-up of the patients as well. And another thing we do is to awareness of the guidance. So we've written lots of guidance on how to handle the samples and what testing needs to be done, and we've just distributed this to all the clinicians in the country by their clinical networks. And we want to do further research, so this is really our first step, but we want to look at different research questions and do some more research further down the line. And we're really acting as a focus for national international collaboration, so we've been doing lots of work with CDC in America, and we have regular contact with them because, as you know, they've been seeing lots of cases for way back, and so they've got lots of experience. So it's really, we're trying to learn together on how to support you and to really do a good job in the surveillance. So the first thing that we need to do as epidemiologists, and joining up the dots, is making sure we've got a good case definition. So unlike in America, we go from the starting point of a case of acute flaccid paralysis, and so that's an individual of any age. So in America, they're looking at under 21s. We ask for any patient of any age being reported to PHE with symptoms of this acute flaccid paralysis, and that's affecting one limb, all limbs, and it's not explained by any other non-infectious cause. And we're looking at cases at the moment from onset date from the 1st of January 2018, and that's the data I'll be showing you. We have a case definition of the acute flaccid myelitis, so that's the symptoms of AFP, but on the CSF you have to have this pleocytosis, which is white cells, more than 5 or more white cells. And you also have to have this the spinal cord lesion restricted to the grey matter that Ben was talking about earlier.
Question.
Yeah.
Restricted to the grey matter, but we've said earlier that it was grey and white.
Yeah, if I may. So,
yeah, please.
So the defining feature is there has to be predominant grey matter involvement. In our experience, 50% of our cases have both grey and white. So they all 100% have grey matter.
Yeah.
And then in half, there is damage occurring not just in the grey matter, but the white matter as well.
But if you're saying restricted to the grey matter and there's no information on there about white matter, are you then discounting if there's cases with white matter involvement as well?
We don't. I think it's phrased as largely restricted, so you could arbitrarily put a number that has to be at least 50% grey matter involvement. So if we saw one that was very typical of demyelination, where there was only white matter without grey matter, we might, exclude that.
Yeah.
But I think it's important to acknowledge that these are definitional, and when people report them, we still get, predominantly over-reporting. So I think we're safe in the sense that we're not missing as many cases, because the entry point for our study is acute flaccid paralysis, not acute flaccid myelitis.
Does anyone know the CSF as well?
It's just when there's lots of cells in the CSF, in the lumbar puncture, when they use to measure any form of inflammation or infection, you get lots of cells. If it's 5 and below, we think it's within normal limits, and if it's more than 5, it just shows you that there's either infection or inflammation going on in the spinal cord. Okay.
So I'll tell you a bit about the reporting and how the reports come to us. So cases are notified to us mainly through this duty doctor service, which is 24/7. So when a case is in hospital, their clinician can phone us up, and then the duty doctor on call will advise on the appropriate lab testing. So this is really important, as we know, to do it in a timely fashion. So the clinicians are instructed to perform the stool samples, so 2 stool samples. They have to be 24 to 48 hours apart, ideally, within 2 weeks of onset of the illness. And also 1 upper respiratory tract sample as well. That's for this is really the guidelines for the polio testing to exclude that, but you can do that for all enteroviruses. So that's the ideal timeliness of it, and so that's a really important message to get out there to the clinicians. And I was at Belfast at the conference trying to get this message out, so for going forward we can really have good sampling going on. So at that time also basic clinical and epidemic. Sorry, yeah, go ahead. No problem.
Prior to 2018 then, what information was available to the clinics?
0.
Really?
Purely the fact that if you said we were monitored and went and sought to say the CDC, only all of a sudden 2018, 2 years ago, not that long ago, prior to that in the UK, the doctors or neurologists were unaware of this?
So they would be thinking about polio.
Correct. I'll show you a little bit of the data of how I was tracking backwards after I recognized that we had missed a lot of these symptoms.
Well, that's great as an individual, but I mean as a network. So if we went into a hospital now, what information?
Oh, now, sorry, I thought you
meant pre that, also there was nothing available, is that what you're saying?
Well, there was guidance on polio and how to, because we need to monitor polio, and that has been known for a long time with polio. So these investigations are related to that. So that's how it came through the polio route, and we saw this increase of reporting of the AFP.
That 2-week window is irrelevant in that case because, for instance, our son, he was tested 10 weeks later.
Yeah, it wasn't recognised.
And diagnosed with transverse myelitis or Guillain-Barré syndrome.
Yeah.
And that's how we started hearing about AFP.
But if we was aware of this as a UK compared to America, they've known about that for years. How are we so far apart?
Well, you're not as far apart as it may feel. So I'm here speaking with a quote U.S. voice, but I'll tell you, in the U.S. in 2016, despite me being on CNN and USA Today and raising awareness from 2014 and 15 and being interviewed over and over again, in 2016, we had plenty of unreported cases.
Yeah.
And so it's raising clinician awareness around rare conditions is very difficult. It is a universally difficult thing to do. And there are lots of ways to try to do it. I give credit to Julia and colleagues going to the Pediatric Neurology Association meeting in Belfast, because it's through efforts like that to try and correct that issue. But what you experienced was a unintentional cognitive deficit.
It wasn't until myself and probably most of the people in the room that stumbled across the EDT report.
I've had families in a hospital up the road who are being treated for Guillain-Barré or transverse myelitis who are Googling this and say to their clinician, do you think this is AFM? And the clinician says, what? What is that? And they're literally 5 miles from my facility. And then they come to see me as an outpatient. And I say, well, yeah, it was AFM. And they say, we knew it. And so that's not a US, UK issue. And to be fair, if you came in and had an unusual acquired movement disorder in my clinic, I'd be sitting there scratching my head. I do this every day, and so it's easy to, call a nail a nail if you're a hammer. But these rare conditions are extremely hard. The reason this has a different flavor and feel from a public health perspective is it's not going away. It's going to happen again, and we're trying to raise the bar. But what you experienced is not isolated to here versus the U.S.
And of course, the mutation could have happened in USA first, and only gotten to Europe afterwards. So it isn't, something can happen in USA and never come to Europe. I mean, that's possible too.
We just learned the French, but we just do that for everything. I have a colleague who's French.
Thanks, Ben. So I think there is issues, and if you're thinking about rare diseases and diseases that haven't been seen for a long time, like polio, nobody's seen that recently, so it's not in people's awareness, so it's really hard to get people to report. And as Ben said, that's why I was at the conference trying to raise awareness with the clinicians. We've been sending them out emails and to raise awareness, really. But at the time, when the clinician does phone up and report the cases, we take very basic clinical information from them, about onset and about what's happening with the case and neurological information. And after that, we then do a detailed follow-up, and the information is all taken to a clinical panel, which I'll tell you about in a minute. But let me show you some numbers. So we've got a poster over there if you want to have a look at the breaks as well. I'm going to show most of the data here, but you can have a look yourself. These are all of our cases in 2018-19. As I said, we started in January 2018. And as you can see, we've had 66 cases. So this is the UK. We've had 66 cases reported to us. Most of them were in 2018. We've had far fewer in 2019. And we ask for all ages. Although we think maybe some of the older ones may not be the same, we want to make sure we don't miss anybody. Hi.
I think a lot of our children were affected 3-4 months prior to that. So
yeah, it's the onset date of the symptoms we go from for just for this surveillance.
Yeah, I mean, a lot of us, we were 20,
Yeah.
but
Yeah.
obviously you haven't set up the task force yet.
No. So we're going from 2018, and some of the cases early on didn't get the right sampling, but anyway, I'll talk about that in a moment.
Even there, you've only got 54%.
Exactly. Yeah, I'm gonna. Yeah.
Even now that it's set up, so.
Exactly. Well, yeah. If I do it in my order, so as you can see, quite most of them, 50 of the 66, are in those aged under 30, and yeah, as eagle-eyed seen that in 2018, only about half had the appropriate samples, but going into last year, we did get that up to 75%. So hopefully, after my little talk on Thursday, we'll get that sampling rate, the timeliness, because that is really, really essential.
It's probably worth mentioning that between 2018 and 2019, what the task force had done, Mary and the lot had, Mary Ramsey leads the task force, had written almost individually to every member of the pediatric college, every member of the adult neurology college, and every member of the infectious diseases college.
We tried to cover all bases.
That's how we think we might have gotten to that figure, but nonetheless, it is still hard work. Yeah.
Oh yeah.
It's keeping it in people's minds, especially when it's this biennial every 2 years. It's keeping the awareness there. So yeah, so it's got the appropriate sampling has got better. So what was enterovirus? So EV is enterovirus. Enterovirus, which ones of those ones that had the right samples, how many actually were positive for enterovirus? This is just the whole enterovirus family. So in 2018 it was 70%, but then in 2019 it was down to 40%. I think that's that biennial thing that Ben showed earlier. As you can see, this D68 strain of the enterovirus, that was all in 2018. We haven't had any AFP cases with the appropriate samples that have been positive for D68 this year.
Which is exactly what Ben said.
Yeah.
Yeah.
It's very similar to what's been seen in the US. So let's look at just these younger cases, the ones that are under 30 years of age. So we've got 50 of those. This is an age breakdown. So as you can see, most of them are in the under 5-year-olds. They're young. They're the younger ones, and it's an equal split between male and female. And this is a interesting slide. So this is month and year of onset of the cases. And as you can see, our first case, the onset we had in July 18, and it's going out to just December 2019. But as you can see, it builds in late summer into autumn, and we had our peak in October 2018. And then the blue bars are the ones that were positive for D68. As you know, only half of those actually had the appropriate samples, so some of those which are in the red could actually be in the blue. But you can see how it peaks in the late summer, autumn. I'll just tell you a bit about the symptoms that have been reported to us. So 67% of the cases actually had respiratory symptoms, which you would expect, but only 15% reported any kind of underlying illness, so they were in healthy people. It is severe, as we know, and because 32% of the total cases were admitted to ITU. And as for limbs that have been affected, 47% had all 4 limbs affected, 36% had 2 limbs affected. Of those, 62% of those were actually the lower limbs. We had 2 patients which had weakness on opposite sides, which is a bit unusual. So going from upper across.
Excuse me.
Yeah.
Sorry, can I just ask a question here?
Yeah.
From what Dr. Greenberg was saying earlier, it seemed polio was more lower limb.
Yeah.
I'm surprised by that statistics. It's more lower limb, I thought it would be the other way around.
Yeah, it's a bit different from what Ben has seen, but this is 66 cases that have been reported to us so far, and these ones haven't been reviewed by clinical panel yet. So these.
That's because you've got to split the 2 different causes of them, using the 68 and the other.
Yeah.
Or is it slightly different?
Yeah, and so the predominant, when we get to that statistic of lower limb only being only 10 to 20%, it's if you restrict to even years between within our season, and then if you restrict further to proven EVD 68 positivity, it really drives down. Once you remove the positivity, the even year, or the time of year, it becomes the Wild West. I mean, it's all over the map in terms of association.
I think the other thing to be careful about is that some of the upper limbs may actually have been milder and actually not reported as well,
Yeah.
number one. And number two, as
Because you
Julia
notice when a kid can't walk, you don't always notice that he can't use his arms perfectly.
and I certainly personally had an experience of a patient being admitted to us 10 weeks after the initial presentation of a flaccid arm, whom the referrer was rejected from another center because they thought it was unlikely to be neurological if it's been going on for that long before coming to see me. And in that patient, it's very likely that they might have had that condition, but we've missed the window to diagnose, as you know. If I was to image him now, I'm probably not going to find anything positive, but the nerve conduction test was relatively, confirmatory of an event in that part of the spinal cord. So I think that's probably the reason why we may not be over-reliant on this years or this 2 years of the data, but the next ones may be more informative if we get it good.
And then the one other pattern we've seen is we've had some kids where the gray matter that was targeted was very high up in what's called the thoracic cord. So it's the part of the cord just below the arms, but the only muscles it directly supplies are the intercostals. And if you get a weak muscle around your rib cage, you just don't even notice. So we noticed the leg, but the lesion was higher up. And actually, that child ended up developing a severe scoliosis because of the weakness right around the spine. So it all depends on where in the cord the inflammation is occurring.
So as I said, those 66 cases are the ones that have just been reported to us, phoned in. They fill out this brief questionnaire. And so our next job is to review all the cases. So as part of the task force, we've set up a clinical review panel with experts from around the country. So they're paediatric and adult neurologists, a neuroradiologist who's the doctor who looks at the MRI scans, an expert in the field to tell us about the results and interpret the results for us. And then we have us epidemiologists from PHE there, and also virologists. And it's really my role is to gather the clinical information on behalf of the panel. So Public Health England has permission in this situation to go to the clinicians, get approval from their cold cop permission at the hospital, and then I go in and I take copies without any names or anything of the clinical information, and then I bring them, and the MRI scans, we get them anonymised, we bring them back and present them at the clinical panel, and the whole panel sits down, talks about the cases and to see how they fit and how to categorise them. And really this is to ensure that we have a complete picture of what's happening, because as Ming says, when the case is first reported, there may be other things that have happened. So we make sure we get everything and do it as systematically as possible. And we also want to look at clinical interventions, so like treatments and that kind of thing as well. This is our complicated pathway of how we describe the cases at the clinical panel. So they're either, basically we start off saying, are they actually acute flaccid paralysis? They've been reported as such, but we look at all the symptoms and all the notes related to how flaccid and all that information. And so we'd say, okay, if they're AFP, then we go on to look at the MRI and look at the information to see if they fit that case definition of AFM. And then they can go into a number of categories, so they can be. So sometimes we don't have all the clinical picture or the MRI scans, so they could go into AFM probable. We're not discounting them, saying they're not, just because we don't have the right imaging or something wasn't done at the right time. So they would go into the AFM probable. And then we have the AFM pending. So if I've missed something at the hospital or there's more information to get, I would go and chase it up and they would go into the pending category. Or they could be AFM confirmed. So that's how we kind of work through the system. So far, as you can imagine, this takes quite a long time to get all the information, and we've done, so there's 66 cases so far, we've reviewed 30 of them, and of the 30, we've confirmed 25 as being acute flaccid paralysis, and of those, we have been able to confirm AFM in 13. And of those 13, 7 have been enterovirus associated, and of those 7, 5 have been tested for D68. So just say something about the testing. The enterovirus testing, they can do that at the local lab at the hospital, but to get the D68 bit, that sample has to be sent to Colindale. So that's another step we need to get people to do. So not only they have to remember to do lots of things to get all the sampling done on time, to send it to the right place, and so there's a lot of things that could be missed. But anyway, we've got 13 confirmed AFM with 5 being the D68. So, MRI scans. I'm going to try and talk to you about just a couple of patients that demonstrate a couple of interesting things. So this is kind of the information we look at clinical panel, or the experts look at, not me, the experts look at clinical panel. This first patient is kind of a classic AFM picture. So the neuroradiologist, Atta, he's kindly put this slide together, but I'll try and talk you through it, but I'm sure other people can chip in. We can see signal change down on the long arrows there, and that localises to those anterior horn cells. And also there's signal change on the brain stem as well. So this is kind of a classic picture on this patient 1. So they've had the MRI scans done at the right time, and you can see that picture. Patient 2, they had a asymmetric left-sided weakness, and on the MRI you could actually see a corresponding left-sided change there in those anterior horn cells. So that was quite interesting to see that, and we didn't usually see that, but that was worth noting. So we can all work it out, 2016, 2018, 2020. We have an enterovirus season coming up, we should think. So we need to be prepared. As I said, I've been trying to raise awareness with the clinicians so people are knowing what they need to do. So I'm hoping we've done that. And so another step we're taking is for AFP, acute flaccid paralysis, to be a notifiable condition. I don't know, there's lots of other conditions which are notifiable, like measles, polio. Well, that's how we came to see this, because of polio being notifiable. We saw this increase of AFP, but we're actually switching it round and trying to make AFP notifiable. So we've applied to do that. So that makes a legal duty for clinicians to report it to PHE. So we're really hoping that's going to really stimulate reporting and help. And so we hope to finish the clinical follow-up by the summer of this year. We're going to probably maybe another 3 panel meetings. We're going to bring all the information together and really get the message out there to get the appropriate samples, the timely MRI, and so we can interpret the data. So there's lots of people to thank, because I'm always on the phone to people they're always very busy trying to get people to fill in forms and get information, but lab staff, NHS staff, the clinical panel, yes.
Is there any research and development gone into vaccination for this G68 strain?
Right, so in the States there is...
Yeah, so we've started in the US with our National Institutes of Health, the NIH vaccine development around TB68, so the early stages is underway. There's also several therapies targeting the virus itself that have been tested, and new ones under development. We're honestly not sure if an antiviral would even help, because once kids are getting weak, and those cells are dying, it goes very quickly. And so my personal opinion is the focus needs to be on the vaccinations.
So earlier you mentioned, so is it derived from the common cold, or is it derived from polio?
So there's 1,000 different viruses that cause a common cold. And depending on the time of year and what's happening, so we all show up sniffling and coughing for very different reasons year over year over year over year. This is one of the, enterovirus D68 is one of those many thousand that can affect the respiratory tract and give those symptoms. And so there's nothing currently that we vaccinate against that would prevent an enteroviral infection. There are no enteroviral vaccines that are commonly used.
Thank you.
Is anybody here from Scotland?
Yeah, we do know some parents
Okay.
in Scotland.
Because I think there was an outbreak, a cluster in 2016
Correct.
before this program started. What are public health, are they doing the same as public?
Public Health Scotland?
Ben may not know, but the NHS is devolved, so Public Health Scotland is different from Public Health England.
So the
Yeah.
task force includes Scotland, so they're part of our
Oh, good.
task force.
Yeah.
Yeah,
So
so
you-
we're all joined up in
You
the.
can work together.
Yeah,
Yes, yes.
Thing on the cluster in Wales, it said Eurosurveillance, so what's that?
Eurosurveillance is just a journal.
Is it? Okay.
Journal where we
cool.
published the report.
Yeah,
our
because they
initial report.
published it in that. So
Yeah,
I just wanted to
it's just that.
Yeah.
It's a journal.
So it's a fast-track journal whereby if you want to get anything published with regards to, viruses,
So the authorities would do that, local authorities would do that. Would they publish it in that? So not from you, but
so it's an open access journal. Anybody can publish it if they want it to be known that this is an important, pocket of disease. So the Welsh did do
so
that.
Public Health Wales could have done that.
Could have done that. And we did it for our England one as well at the beginning of the year, right at the peak, because it just highlights that it's out there, people get the signal, and then everybody keeps watching.
I wasn't sure if they were an authority or if they're just a journal then.
Yeah, it's just a journal. Cool. Getting information out.
Yeah. So I don't want to repeat a lot what Ben had said, but I wanted to bring up three, important things that I think is slightly different in the UK. I think the first is that because our surveillance includes patients predominantly with just acute flaccid paralysis, we are going to capture slightly different cohorts of patients. And the one that Julia showed you with the imaging on the left-hand side, as you saw there, where there was a slightly asymmetric presentation, slightly asymmetric imaging change, but not much in terms of, pleocytosis, for me would probably fulfill the criteria for, an intraviral disease if the child had EV68 or whatever, but not fulfill the criteria for acute flaccid myelitis. So we need to be careful how we define, those cases, but we'll come to that, a little bit later. The second, obviously, is that, this is a disease that we only recognized, from 2016 onwards, at least in the UK. And a lot of what Ben mentioned, i.e., cognitively as clinicians, we were all taught, transverse myelitis. And my story almost mirrors what Ben showed, and I'm not going to take you through all the three cases, but I had a fellow at the time who was visiting from Spain, and we had three cases. One was transverse myelitis. I'm just going to quickly show you the case where there is inflammation in the spine on the left, where there's little inflammation there. But the next two cases that she saw during her 6 months with me was very atypical. This was an 18-month-old girl, and you can see the first 24 hours, there's very little difference. You get a fever, you get unwell. And children don't tell you they've got, they're unwell. They just behave that they're unwell. And if you examine them carefully, you would find the changes. But very atypical to the changes, as Ben was talking about, the stiffness that you get from the Y1, you get flaccidity, and they're lower motor neuron signs. They just do not add up. And the changes that you can see there are very typical of what we would see in inflammation that's derived from, or what we call associated with viral, activation. And that can be in a whole host of virus, but enterovirus, is one of them. If you measure the CSF, it is elevated. So this is the pleocytosis bit. So you get a reactive CSF, meaning that, the cells are being recruited into the brain because of the infection or in attempt to try and fight the infection. If you measure the conduction of the nerves, you get a clue that the nerves to the anterior horn cell is affected, or sometimes distally to that as well. And in this case, enterovirus 71 was identified. She had treatment. We can talk about the IVIG plex in a paradigm, but she improved, but that arm remains flaccid all the way through. So the recovery, just be careful. Upper motor neuron, inflammation, we can recover. Less certain about the lower motor neuron wire 2 effects. But could we have done differently? Would physiotherapy have made a difference? Would other aspects have made a difference? And you'll hear about nerve transfers and things a little bit later on. Almost the same time, like all things, buses, they come in twos, and then you never see them again for a little while, and then they come again. This happened in 2016, both these cases. Again, viral prodrome, not well. She was a little bit odd. She was a lot sicker, so there is a lot of peripheral sort of inflammation, perhaps, going on as well. But because she was so sick, she actually had plasma exchange in addition to the IVIG. See the sequence there, started pretty late before plasma exchange was initiated. But after plasma exchange, she did very good recovery, started to sit up and discharge, and very surprisingly, at 2 months, had no motor deficits at all. The one thing I wanted to show you here and go back to this here is that in addition, you can see that these are just very subtle changes, but it's in the central cord, and this is what we call TM plus in 2016 because we read the literature and we said, Ben's.
That's why we got that diagnosis. They've read your paper.
Yep.
I'm very sorry.
I'm not.
I mean, I publicly apologize for this. I'm not trying to hide it.
So I think what this sort of illustrates that we were so pleased with ourselves, thinking, this is TM plus. It's similar to the cases that Dr. Greenberg had described, and we had to coin up something different so that the journals would publish it, so previously described. And then it was suddenly clicked as I was just looking through the literature, preparing this, saying, am I sure this is really TM plus? Because this was in the background. And then I went back and looked at a lot of the TM literature. You can see this bimodal distribution that you see there. The under 5, there's something very different, about the under 5. So I was fortunate enough to be involved with 2 big studies in the UK. The first one is a big surveillance study of all children presenting with inflammation in the brain, spine that is due to myelin-related condition. And we reported this. This was, however, in 2009. In 2010. This is more of an academic challenge rather than, and knowing whether it existed then, right, and then now. And I looked through all the 40 cases of transverse myelitis reported, including the imaging, and I could not convince myself that it was definitively a case, but it was very limited data. It is surveillance data and imaging data. Fast-tracked, we then had another study looking at all children presenting with this condition that was prospectively followed up over a period of time, over 5 years. This started in 2019 and ended in 2013. So we might have captured some of the 2012 data. We published it with the French, looking at all the cases of transverse myelitis from that cohort. I went back pretty carefully and looked at that data set. Again, pretty limited. Could not find, very much signaled that there might have been cases of transverse myelitis that was atypical with those features, so hence AFM. And then I gave up. I said, okay, I'm just going to look through all the 10 years through my hospital. And there were 33 cases of transverse myelitis. And when we looked back very carefully at the notes, at the history they present, at the flaccidity, it then struck that they were definitely cases that we had missed. And these were our cases that we think would fulfill the AFM criteria. Now, in 2011, 12, and you can see consistently at those 2 years, nothing in between those. There was 2 cases. So I am delighted that, you here are saying that you were, diagnosed in 2016 and some, even before that, supporting that there might have been a signal, not as big as now, obviously, in those years, as well. Coming back to acute treatment, you've heard about the steroids, you've heard about IVIG, and you've heard about Plex. IVIG is tightly regulated use in the UK. It is a grey indication for a lot of these conditions. We can get it used in acute situations, but if there was a means of not using it, we would be very, very pleased. And so there's a big drive to actually get PLEX instituted first before IVIG. Otherwise, we would be wasting IVIG, as was mentioned already.
Yeah, because it just, like you're saying, it just clears it all out, right?
So
We had steroids first, then we had a week of IVIG, and then because of the parent group in the US, people like hyperventilation and things like that, one particular mother was really promoting PLEX, so we insisted on that, and then they started doing it, and that's when we started to see the difference.
Correct.
I think the trouble we had with Flex was that we were at St George's and they hadn't really done it for kids under a certain weight, and it was quite unusual to be doing it on a 2.5-year-old at that stage. So we had to move to Great Ormond Street. So I think IVIG was something they could do immediately, and they'd do it all the time. So
Sure.
we might as well do that.
Correct.
Whilst we sort of wait for you to have a transfer. So maybe they thought Flex might have come first, but
Yeah.
it's just the way that I don't think everyone's trained to do Flex.
Sure.
They go to certain centres, whereas
So what we're trying to do with, so NHS England recognized that there is a deficiency in being able to provide PLEX in a lot of centres, and they've worked very closely with a team called NHSBT. They were actually the blood transfusion services, a hematological service that was set up to provide PLEX, and we're working very closely with them to develop a portable team that can be sent out to various hospitals. So currently the model is that they set up what they call a service level agreement with various hospitals. These are expert teams that will go and produce PLEX. At the moment, you have to have kit with you, and you have to have a service level agreement. You phone them, they come within 24 hours. It's revolutionized our management with PLEX.
When did that start? I didn't know about that.
2 years ago.
Okay.
Yeah.
Because, of course, adults with TN wonder why they never get PLEX when they compare against America. Okay. And the reasons when I've gone into it is usually that the equipment is held by the kidney doctors for dialysis, and the neuros can't get hold of it, quick enough. And there's infighting in the hospital. There's not enough. This is busy, and so this would be.
Yeah.
Whereas when we compared with America, there was a much higher use of plasma exchange for adults with TN. So I'm delighted to hear. I didn't even know that was happening.
Yeah.
So it's addressed.
So I think for me, this is going to be hopefully the game changer. I think the one thing that, at least in pediatrics, is that you would still need to get the child to a pediatric neuroscience center because the monitoring is slightly more complex than you would be in an adult. But to get it to every district hospital that sees pediatrics, I think it's going to be difficult for twofolds. I think, in fact, the physicians actually looking after the child would be worried, as well as the person. So, for example, just before coming this morning, I had a child with an antibody-mediated disease present with a catastrophic optic neuritis. They've had 3 days of steroids. I've just got the team to come out today. So they do weekends as well. So it is a proper 24-hour service. So I would say watch this space.
Which, of course, works better in a small country like UK than,
Correct.
say, in America.
Exactly. And I think it's also the realization that we will not be able to spec every 23 neuroscience center to have the expertise to be able to deliver it, whilst if you have an expert team that goes out and does it, it's effective. Don't get me wrong, they are very, the administrative components of this is high. Who is ultimately responsible, if something goes wrong, etc., etc. It's not easy, but the framework is there, and at least 5 pediatric neuroscience centers, including ourselves, Great Ormond Street, are using NHSBT.
What are the others? You mentioned Great Ormond Street yourself is
Evelina, St Thomas's, 3 hospitals, I think Newcastle in the north, Liverpool, and also Manchester. But doesn't mean you don't have to use them if you have a good existing service that you could draw on the hematologist or the renal, etc. So it's not an exclusivity, it's just a resource that is there if you want to use it. So for example, we have our own plasma exchange, but cannot accommodate neurology all the time. That's why we've used them instead of the renal team or instead of that. But they've been so efficient now that we would not think about any alternatives, is what I would say. And so they're also tasked at collecting collecting the information, because there is a sort of vested interest for them to want to promote the service. So they'll be collecting all the correct data of improvement, etc., etc. So improvement in plasma exchange is quite difficult, as you know, to collect, because you give everything, at the same time. So there are two components there. It's the early improvement. It is actually not, making sure you don't get worse is another perhaps outcome measure, and then one, a lot later as well. So it's work in progress, and I think this really illustrates, Ben has showed you this already, why we think we need to be aggressive as early as possible, within weeks, in fact. This was the rationale of that. And a lot of times you talk about safety. So they would worry about children under 2 or under 10 kilos. Ben didn't tell the story about his intensivist phoning him up, or the surgeon phoning him up, to putting a line in a baby that was 6 months old, and I think they are technically difficult, but most surgeons, as we start to use them much more, are much happier with that. So it is developing the expertise, particularly in the very tiny ones.
It's quite a high risk factor.
Yeah, so we've looked at the pooled risk, and this is why we had to develop it in conjunction with the groups to help identify what the specific risks are. A lot of the risks that are found are actually related to the procedure itself. So if you're taking blood out and you're putting blood in, you can get electrolyte imbalances, you can get changes in blood pressure, but done correctly, done in a team that delivers it day in, day out, it is minimized. But nonetheless, you will get the risk of infection, life-threatening infection, that is no higher sometimes than even steroids. So we've out of 500 cases done there, it's less than 1% of life-threatening sort of events. But don't forget, if you're in intensive care with AFM, you are in a life-threatening situation already. Correct. And then I was just briefly touching on outcome, because we know very little about this condition. As you know, if we have only started collecting them from 2018, we're only halfway, through the cases. We would need to do twofolds. We would either draw on the experience of the, Americans, and these are 3 published papers that I identified. So we know, we talked about Y1, we talked about Y2. The outcome for Y1, we can probably borrow from transverse myelitis. But the outcome of Y2, whereby the flaccid weakness appears to be the one that we need to concentrate on. To date, most of the data appears to suggest that persists a lot longer. And if you look at all the papers earlier on, demonstrating that it persists a bit longer, it hasn't quite started to report the longer term recovery as those. So I think that's the important bit. Although it takes a lot longer to get there, the potential for recovery appears to be more consistently reported these days, and you wouldn't see that. So you would hear people like Dr. Greenberg, talk about that. You would hear anecdotes of some patients doing that yet before you see the report.
When you say a lot longer, you mean
compared to
spastic paralysis?
Correct, yeah.
Can I just ask, how muddy is the water? So with AFM, you obviously get the grey going into the white.
Yeah.
With TM, do you get the white going into the brown?
Correct. Totally muddy, grey. I went back and looked at this study, of ours, 95 cases, 50% was said to have central grey involvement. That's why I worried that, might we have included, some of the patients with in there as well.
So just based clinically, and so this is where, technology is wonderful, but can lead us astray, and a reflex hammer is helpful. So I'll have patients who fit the criteria for transverse myelitis, not AFM, and on their MRI, they have a big central cord lesion that seems to involve both, but clinically, when I go tap on the reflexes, they are not having depth of those cells. So the MRI might be swelling, the tissue might be swollen, so the MRI says the gray matter is involved, but functionally, there's no damage happening in any appreciable way. Whereas, and I appreciated the comment earlier being in terms of when defining AFM, we start with you need to have evidence of at least one flaccid limb. We need evidence, not just from the MRI, but we need clinical evidence that those anterior horn cells, those wire number 2s, are not functioning. And then we pile on the MRI.
So with TM, no facilities, all going to be spastic, right?
Yes.
Right.
So
Unless in the hyperacute.
in the first, so that only applies. So in the first 24 hours, everything's out the window. And that's a long story as to why.
Yeah.
But if in that first week we're seeing spasticity, it is not, I think it's fair to say,
Correct.
We would not diagnose it
So
as acute
that's
flaccid. You have to have flaccid.
Flaccid.
And that's why that case I brought up when it was a thoracic cord lesion was tough, because their lower limbs were spastic,
right.
but they were flaccid intercostal muscles, but there's no reflex hammer for the intercostal muscle. We literally actually just saw fasciculations and other things. But so very rarely that can be difficult, but most of the time, so if you have a cervical lesion, a neck lesion, and spastic arms, that is not acute flaccid myelitis. So the MRI just tells us tissue is normal or not. It doesn't tell us what the abnormality is, whether it's swelling or cell death.
Correct. And I think that illustrates how, a single center study where you are the primary principal investigator, you've seen every patient and you have access to every patient, you have the confidence when you go back to the notes. Whereas in a multi-center study, much as you think your colleagues are excellent, I think you have to be, have some, common sense, allowing for misreporting, missing the boat, etc. And always, I think in studies as well, there's an eagerness to recruit patients to make the numbers. So we're also well aware of that. So I'm going to just end now by mapping out what has happened. This is the first report that Ben was talking about prior to the group talking about all the sporadic cases across the UK, across the US, and as they sat down to look at the cases, the CDC reports came out consistently demonstrating the numbers perhaps increasing gradually. I'm not sure we are confident that it has reached steady state. Might be more, might be less. You saw the fluctuations. And around the same time, we have the UK cases. Although 66 were reported, I had actually projected that 45 was going to be, confirmed, but that number might be a little bit smaller after having been through the first half of the cases. But if the number and the frequency based on population was to be, sustained, and we might see, an increase in the next outbreak, which would be, very soon, might we see up to 100 cases, and that would be an incidence of about, 1 or 2, per million population. So not wanting to be left behind, and Todd unfortunately could not make the meeting today, having recognized how difficult it was to actually extract information from, clinicians in little hospitals. So I suppose what we didn't mention was that of the 30 that we have evaluated, they were from centers where there were 5 or 6 cases, and it was actually very easy to go in and get them. The rest were in individual hospitals scattered around the whole of the UK. And I and Julia were not absolutely convinced that we were going to be sort of comprehensive and be able to get that. So we thought, let's do it the other way around. We have submitted an application to the NIHR to turn it around that we would offer the evaluation at a few centres scattered around the UK, whereby patients would be recruited to the study up till 2018. So we have to start with 2018. We will then extend that to the retrospective cohorts previous to 2018, but also be ready for the prospective group. And this is hugely inspired by the capture study that you heard about, the collaborative work. And we hope to draw on the experience when the team published on the outcome measures that are best for AFM, but we borrowed, some of the potential ones there. So ultimately, we know it's there, we know it's coming back, we've got to be ready. And I think all your engagement is absolutely, vital in this, both helping, promote the condition, but also identify, patients who want to come and be part of the study. I ended on 2 notes about key research questions, but every single bit of them you have asked already and has been answered, in the question. And I think the only bit that is missing now will be featured in the next 2 sessions a little bit later about how best to recover from that, and are there any other interventions that can improve that? I wasn't very sure about the sort of host factors that's out there at the moment. I think the data is too small at the moment, but Tom and I was having a conversation about, do these patients have polio, demographics, or are these patients, slightly different? At least certain American cohorts have suggested that it might be slightly different to the polio cohort in that some of the host factors may not be entirely the same. So male ancestry. Asthma is not difficult to see why, because you've got sort of respiratory illness and a previous history of sort of head injury as well. So some things happen to trigger the immune system perhaps, or something happens to have triggered an injury that causes then the immune cells to get into the brain, or the virus to get into the brain to cause that problem. But this paper was only about sort of 30 cases, so I think one has to be careful. But the US, who are 500, 600 cases ahead of us, are starting work on the genetic components. There will be some factors. There will be some environmental factors that trigger the process. Is it a prior exposure to an enterovirus-like bugs that then primes your immune system to recognize the enterovirus before the next proper enterovirus comes, that make you more likely to have a brain-directed or spine-directed or anterior horn cell-directed autoimmunity? Is something we would be looking out for alongside all the therapies, because there's no point studying about biology, because ultimately we want to prevent this from happening. If it does happen, we've got to stop the neurotropic damage. Neurotropic meaning how the nerves and how the neurons are damaged. So I'm going to stop there because we've overrun from all the very interesting questions.